We are now going to talk about the treatment of coagulation disorders, and the information is in chapter 38 of your book, and we'll talk about how this relates to our cardiovascular system. In order to understand coagulation disorders and subsequent treatments, we must first understand the normal process involved in hemostasis. And hemostasis is the process by which the body stops bleeding after an injury. Now, this is important to minimize blood loss in the body. There are 13 clotting factors that are involved in hemostasis, and we're going to talk about the sequence of events here that occur when an injury happens. So the first step is a vascular injury or endothelial exposure. The body senses some type of injury. There will be immediate vasoconstriction to stop the leakage of the blood, and there will also be activation of clotting factors and platelets. Second, adhesion will happen. So you have glycoproteins like collagen and von Willebrand factor that bind the platelets. They will cause this adherence. Third, you will have activation. This is when the platelets are activated, and they also change shape. This is going to activate other platelets and other clotting factors to come along. Number 4, you have aggregation, and this is when platelets release adenodiphosphates, or ADP, and thromboxane, A2. These are different types of platelet activators. These are going to help to form a visible clot. Number 5 is the formation of a fibrin plug with a blood clot. So this is going to be a meshwork of proteins that form a tough kind of protein clot. And number 6 is actually clot retraction and dissolution. So this is the breaking up of the clots. Another name for that is fibrinolysis. This is where the clot is destroyed at the end of the process, where you create a fluid state with the blood again. So the coagulation cascade is what we've just kind of talked about. Those steps, there's an intrinsic coagulation pathway, there is an extrinsic coagulation pathway. The intrinsic is activated in response to an injury of the blood vessel inside of the blood vessel. The extrinsic coagulation pathway is activated when there's an extravascular injury from surrounding tissues. Regardless of whether the clotting is initiated by substances internal or external to the blood vessel, coagulation ultimately will follow the same pathway of the clotting cascade or the coagulation cascade. This is an example, a diagram of that intrinsic pathway and extrinsic pathway. It is a very complex pathway. You can see there's many things happening along. Clotting factors do start out in an inactive form, and then they become activated. Near the end of the pathway, you have prothrombin that becomes thrombin. Thrombin is then going to convert fibrinogen to fibrin. Thrombin is a very powerful enzyme in the coagulation process. Vitamin K is also kind of an important thing within the coagulation process. It's necessary for making 4 of the clotting factors. And vitamin K is made by the bacteria in the intestines. The liver will use the vitamin K to make these 4 clotting factors that are necessary for the coagulation cascade. I don't expect you to memorize this. It's just kind of a reference for you if you'd like to look back on it. So there are many diseases that affect hemostasis, many that you will see as nurses. One of the biggest is thromboembolic disorders. So this is when your body is forming undesirable clots throughout. The clots can form and cause blockages, or can break off and cause a blockage somewhere else. They can be venous or arterial. If it's in the venous, it can cause venous stasis. It can cause a DVT, a deep vein thrombosis. So with that thromboembolic disorders, you can have procoagulation factors accumulating, and again, you can have the deep vein thrombosis, so the clots that are sitting in the periphery in the legs. These can be caused from immobility or some type of trauma, surgery, hypercoagulated states, and some drug therapies can lead to DVT, such as birth control pills. Another possible embolic disorder is pulmonary embolisms. These are clots that dislodge from somewhere else in the body that migrate to pulmonary vessels in the heart and the lungs. So you can have blockage in the lungs, and then you can also have blockage to the heart. You can also get clots that travel to the brain and cause strokes. So these thromboembolic disorders are very serious and cause a lot of trouble for our patients. So anticoagulants are the first group of drugs that we are using to prevent clot formation. They're going to lengthen the amount of time it takes to form a clot. The three main ones are heparin, warfarin, and dabigatran. So we'll talk about heparin first. This is the drug of choice to treat thromboembolic disease. Heparin is a natural chemical found in the liver and the lining of the blood vessels, and it's also obtained from animal tissue. It is a type of carbohydrate. The mechanism of action of heparin is that it's going to bind to antithrombin 3, which is inhibiting thrombin and inactivates factor 10A. This is going to prolong the coagulation time, so it's going to prevent clots from forming, and it's going to prevent existing clots from getting bigger. It's not going to do anything for existing clots. It does not break up existing clots. We will talk about another group of medications that do that. So in this case, heparin will prevent clots from forming and will prevent clots from getting bigger. Many times heparin is given as a low molecular weight heparin type. This is, you might have seen as Lovenox. Lovenox is a nice alternative. It has a smaller dosage to it many times and more predictable results. It's given subcutaneously in the abdomen. You will find many of your patients on Lovenox. It's a very commonly used type of heparin. So indications for heparin, again, is DVTs, pulmonary embolisms, MIs. Also used for unstable angina, which is when we have that decreased blood flow in the coronary arteries related to plaque buildup. The nice thing about heparin, it is okay for pregnant women to take if needed. It does help keep clots from forming in different types of IV lines, peripheral lines, central lines. They use it many times in dialysis, in the types of access devices they use in dialysis. It's referred to as heparinizing the line, or you may have heard the term Heplock. That is when they stick heparin in to try and keep those clots from forming. They will use heparin as an emergency IV bolus, which means that it's just a large amount going in at once, and then they can change it to a continuous IV infusion for emergent situations. You will see heparin being tapered, so they will change the amount of heparin that is given, the dosage, based on the patient's response. And the lab monitoring used to evaluate heparin is APTT, or activated partial thromboplastin time. This is what the nurses will be tracking to determine how effective the heparin is for the patient. So a normal APTT is about 25 to 35 seconds. When a person is on heparin therapy, they can be increased 1.5 to 2.5 times that normal value, just depending on their specific situation. The adverse effects related to heparin are related to that prolonged clotting time. So you're going to have bleeding. Now, not all bleeding is bad. Some minor bleeding is okay. It's not going to cause a huge problem for your patients. This is dose dependent as well. So the higher the dose, the more likely the bleeding is going to be happening. Bruising is a very common side effect, nothing to really be too concerned about. You will find bruising in the abdomen with Lovenox injections especially. Some patients have more severe bruising than others. You will also find prolonged bleeding from invasive procedures. If they are getting lab draws, you might have to hold pressure on the site longer. You might find bleeding from the IV site if you're trying to do an IV start. That is all pretty typical things that are seen with heparin. When you want to worry is when the bleeding is seen in the stool or in the urine. This is showing that the bleeding is happening systemically. So we want to look for those and be able to intervene if need be. So bloody stool or dark tarry stool, urine that has an orange color to it or is looking bloody. We definitely are concerned about those effects. So hemorrhage is a problem in about 10% of patients that are on heparin. It can be fatal, especially if your patient has some type of injury, say they fall and they hit their head. They can start hemorrhaging because of this clotting, prolonged clotting that's happening in the body. And that can lead to death if it's not handled quickly. Another kind of rare but serious side effect is heparin-induced thrombocytopenia. It's also called HIT. This happens about 5 to 10 days after onset of therapy or treatment. This is where you have activation of the platelets that causes a paradoxical increase in thrombotic events. So despite heparin therapy, the person actually is clotting more. This can occur in about 30% of the patients. And the interesting thing is that the platelet count drops. So the platelet count drops, but the thrombotic events increase. And what you're looking for is those platelets. You want to track the platelet level. If it's below 150,000, you have to be very concerned about that. That's an indicator of this HIT. So constant monitoring of platelets is important in heparin therapy. Some other side effects are hypersensitivity. Hypersensitivity can happen because heparin is produced from an animal tissue that can have contaminating antigens to humans. So we have to be concerned about that. Osteoporosis can happen in long-term high-dose therapy of heparin. It's going to change the bone density, the bone metabolism, the heparin, if a patient is taking long-term amounts of heparin. This is a picture of Lovenox. This is what you'll typically see as the injection for that Lovenox therapy. Okay, we're switching to our next anticoagulant, which is warfarin, or Coumadin is the brand name. This is the most popular oral anticoagulant that is on the market, and the mechanism of action is that it's going to inhibit a couple of the enzymes that form vitamin K. So we know that vitamin K is needed in making those certain clotting factors, so it's going to inhibit some of that vitamin K from being made. It doesn't affect the clotting factors already circulating in the blood, so we have to kind of wait for a therapeutic effect about 3 to 4 days for those already circulating factors to go away. Let's see, so with warfarin, we use it for a prophylaxis for thromboembolism disease. Strokes we use to treat TIAs, which are transischemic attacks, little clots that are forming that can lead to a stroke. We also use it for MIs. We use it to treat AFib to prevent any clots that form in the heart from atrial fibrillation. It's used as a treatment and prevention of DVTs and PEs in surgery patients, so status post-op surgery. Many times those patients are at risk for DVTs and PEs, so we want to many times put them on warfarin to treat or prevent that. Also used in patients with prosthetic heart valves because they are at a higher risk of forming clots as well. So warfarin is monitored on a weekly or monthly basis and adjusted accordingly. which is kind of one of the downfalls of this medication. It does require quite frequent monitoring. So the monitoring is a PT-INR, prothrombin time international normalized ratio test. A normal PT-INR, PT would be about 11 to 13.5 seconds, and the INR is 0.8 to 1.1. So on therapy, they bring the two together, and they want the ranges of therapy to be about 2.0 to 3.0. Of course, there's more specifics for each individual, but as a general sense, they want those lab values to end at 2.0 to 3.0. So on therapy, that's what you will expect to see, with some variation between that. And you'll find interesting kind of dosages set up for individuals. There are actually Coumadin clinics out there that is all they do is monitor the PT and INR of these patients and make sure that the adjustments are made accordingly so that they are getting good effects of anticoagulation from the warfarin. Adverse effects are very similar to heparin. You're going to see bleeding as a possible adverse effect, bruising, prolonged bleeding from invasive procedures. Again, we worry about the systemic bleeding, the bloody stool, the bloody urine. We worry about keeping our patients safe from injury if they're on Coumadin therapy, warfarin. We want them to be careful not to do any strenuous types of activities, anything that's going to lead to falling, hitting their head, causing a severe injury, because they will bleed from that, and then that could lead to further complications leading to death. So hemorrhage, of course, is what we're concerned about with that. This can also cause osteoporosis and bone fractures related to that bone metabolism, and they don't really have a good establishment of why this happens, but there is some effect there. And warfarin can cause fetal abnormalities and death, especially in first trimester pregnant women when the bone and cartilage development is occurring. This medication was actually used to kill rats back in the day. So they would put it out and it would make the rat problem go away. So here's an ad for you on killing rats. Kill them with warfarin. Important considerations with warfarin: we do have to be careful. There are many drug interactions that will increase the risk of bleeding, excessive bleeding, or decrease the anticoagulant effect of warfarin. Drug interactions that can lead to increased bleeding include acetaminophen, aspirin, and your NSAIDs like ibuprofen. So in combination with warfarin, you're going to see an increased risk of that bleeding. Certain things that cause a decreased risk, especially, are the foods that are high in vitamin K, the collard greens, spinach, kale, turnip greens, green tea. Those are going to counteract the effectiveness of the drug. You also want to avoid certain herbal supplements. Ginkgo, garlic, cranberry, and ginger. They increase the risk of bleeding in these patients that are on warfarin. And our third anticoagulant is dabigatran, or Pradaxa. This is a little bit of a different drug. It's going to inhibit the action of thrombin directly by binding to it so that it can't work correctly. This is one of the newer oral anticoagulants on the market. It's more expensive, but you don't have to do this constant lab monitoring that both heparin and warfarin need. And another benefit is the effects can be quickly reversed within a very short period of time if needed. Adverse effects, again, are similar to the other two. You're going to have bleeding risk. There is a problem with abrupt discontinuation. This can increase the risk of a thrombotic event. So we have to be careful not to abruptly discontinue this drug. It's also contraindicated in patients with mechanical heart valves, whereas Coumadin, warfarin, is the one we want to give patients that have mechanical heart valves. This one we don't want to give to patients with mechanical heart valves. It's actually going to increase the risk of stroke and bleeding in those patients. So yeah, it was approved in 2010. It's the only direct thrombin inhibitor given PO. So it's a nice type of drug that might work out for your patients over the other two. Okay, we're now going to switch gears to antiplatelets. These are used to reduce the aggregation properties of platelets. So our main three are aspirin, adenosine diphosphate or ADP receptor blockers, and our final one are glycoprotein 2B3A receptor blockers. So antiplatelets, the main first one is aspirin or acetylsalicylic acid. The mechanism of action is that it's going to bind to cyclooxygenase or COX enzyme in the platelets. This is going to inhibit the formation of thromboxane A2. And we know that thromboxane A2 is an activator of platelet aggregation. So this is going to block that. A single dose can last quite a while, as long as a week. So you want to avoid other coagulant modifiers that you might have the patient taking. It is used as an MI prophylaxis given for suspected coronary thrombosis, so a suspected MI. We many times will have patients chew on an aspirin to get it into their circulation quicker, get it disintegrated quicker. Aspirin has many other uses besides an antiplatelet. It is used for pain, inflammation, and fever. It was approved back in 1939, so it is a very old drug. There are some side effects with aspirin. It's going to cause hypersensitivity reactions in some people, which can be anything from bronchospasm all the way up to anaphylaxis. It does cause stomach irritation, ulcerations, and some stomach pain. It can be very hard on the stomach, so you want to be careful about taking with food to alleviate some of that. In high doses, it can lead to a GI bleed, and in high doses, tinnitus or hearing loss can occur for aspirin. Clopidogrel or Plavix is our next one. This is going to work by blocking the adenosine diphosphates on platelets, or the ADP. ADP is needed to activate platelet aggregation. So by blocking that, the platelet aggregation can't happen. So inhibition of platelet function can last several days with this drug, even after it's DC'd. It's used as a prophylaxis, again, for arterial thromboembolism, stroke, and MI. Again, adverse effects, bleeding. It does have the same tolerability as aspirin, and really there's no other major adverse effects related to it. Glycoprotein 2B3A inhibitor, abciximab or Riapro, is our prototype. The mechanism of action is going to bind the glycoprotein 2B3A receptor sites on platelets. So because of that, it's going to prevent fibrinogen, von Willebrand factor, and other procoagulants from binding and happening through the cascade. It's only given as an IV infusion. This is a major drug that's used in coronary angioplasty procedures, where they go in through the femoral artery to revascularize arteries, the coronary arteries. So it's given IV only. It's given during procedures. The adverse effects are abnormal bleeding. So that's something that really has to be monitored closely by the nurses. The effects of this can last up to 10 days. Thrombolytics is our last class of drugs. These drugs are going to work by dissolving existing clots in your patients with MI or stroke. So the process of fibrinolysis is breaking up those existing clots. And the two main types of thrombolytics are alteplase and streptokinase. Alteplase, you might have heard TPA, tissue plasminogen activator, is a common one. And streptokinase, streptase, is another name. We use these pretty interchangeably to do just that, dissolve existing clots. So the mechanism of action for these drugs is to convert plasminogen to plasmin, which is actually going to dissolve the clots. It's going to dissolve those strands, fibrin strands, which is what we want. We want them to break apart. It's used emergently to treat MIs, pulmonary embolisms, ischemic strokes. We also use it to open clotted central lines. So if you have a central line that is not functioning properly, we can use these drugs, thrombolytics, to open up those lines, and they work really, really well. So you might see that when you're doing your clinicals and then when you become a nurse. Adverse effects are bleeding is the big one. Report signs and symptoms of bleeding immediately, because these are your biggest, best types of clot bursting, clot busting meds. So they can have that major effect of bleeding and hemorrhaging. So all those things we've already talked about related to bleeding and hemorrhaging, and where we're really concerned when it's seen systemically, we want to monitor our patients for those things closely. And hemostatics, just real quick, we'll touch on hemostatics. Aminocaproic acid, or Amicar, this is thinking reverse of what we've already talked about. This is going to cause clotting. We want it to clot the blood. This is the drug that we use when we have excessive hemorrhaging, or when your patient has hemophilia. They might use this drug for them to clot the blood to stop the bleeding. So opposite of what we've been talking about. It's going to block the sites on plasminogen and plasmin to prevent the digestion of the fibrin clot. So we want the clot to be present. The side effect of this is that it is going to increase the incidence of thrombosis. So if we're promoting clotting, of course you're going to have the issue of too much clotting. This drug is also only given IV, and very specifically in situations where there's excessive hemorrhaging happening. If there's a surgery happening and the patient is bleeding from the surgery, they will use this after procedures, especially for people like hemophiliacs who have procedures done. Say they have a dental procedure and they're bleeding, they might use this drug on them to stop that. That is all for our coagulation disorders. 38.1 is a good summary for these drugs if you're wanting to look at that. There's also the coagulation cascade, which we ran through quickly. So take a look at that in chapter 28. And let me know if you have any questions about any of the information from today. Thanks.